February 3rd, 1945. Field hospital 2 miles behind American lines, Luzon, Philippines. Corporal Kenji Tanaka regained consciousness in confusion and terror. The last thing he remembered was the explosion. American artillery striking his position. Now he was lying on a clean bed, his wounds bandaged, an IV tube in his arm. Then he saw her. An American woman in military uniform with captain's bars on her collar, checking his vital signs with professional efficiency. Not a soldier. A nurse, female, enemy impossible. Tanaka's mind struggled to process what his eyes were seeing. Women didn't belong in war zones. Japanese military doctrine was absolute on this point. Women remained in rear areas, far from combat, performing support roles only. The idea of women operating near front lines was inconceivable. Not just impractical, but morally wrong. A violation of natural order. Yet here was an American woman, clearly a military officer, working calmly in a facility so close to the front lines that Tanaka could hear artillery fire in the distance. She wore the same exhausted expression as combat soldiers, the same 1,000-yard stare that came from weeks under fire. Her uniform was mud-stained. Her hands moved with the practiced efficiency of someone who had treated thousands of casualties. Captain Margaret Maggie O'Brien, 28 years old, noticed her patient was awake. She had been working 16-hour shifts for 3 weeks straight, treating American and Filipino casualties from the brutal fighting on Luzon. Adding Japanese wounded to her caseload hadn't changed her approach. Wounds didn't have nationalities, patients were patients. Through a Filipino interpreter, she asked Tanaka basic medical questions: pain level, ability to move his limbs, whether he could feel the IV in his arm. Her tone was professional, almost gentle. She checked his bandages, adjusted his IV flow, and made notes on his chart before moving to the next bed. Tanaka's shock intensified. This wasn't how enemies behaved, and it certainly wasn't how women behaved. In Japanese military culture, women were protected, kept far from danger, never exposed to the brutality of war. Yet this American woman operated within artillery range, treated enemy wounded without apparent fear or hesitation, and carried herself with the authority of a combat officer. What Corporal Tanaka couldn't know, what no Japanese soldier could have been prepared for, was that he was experiencing the collision between Japanese gender ideology that kept women far from combat zones and American military nursing that deployed women directly into war zones based on simple operational logic. Wounded soldiers near the front needed immediate expert care, and Army nurses provided that care more effectively than male medics alone could. Over the next days, Tanaka would witness American nurses working under conditions Japanese military culture deemed impossible for women, performing surgery while artillery shook the building, treating casualties while wearing combat gear and carrying weapons for self-defense, maintaining professional composure while exhausted, traumatized, and frequently under fire. He would see nurses evacuate wounded during Japanese counterattacks, see them work through injuries sustained when their hospitals were shelled, see them save lives with skill that exceeded most Japanese military doctors' capabilities. And like thousands of other Japanese POWs who encountered American military nurses, he would experience profound cognitive dissonance. Everything Japanese culture taught about women's capabilities and proper roles was being contradicted by direct observation of American women performing under conditions Japanese doctrine said women couldn't handle. This is the story of how Japanese soldiers encountered American nurses operating in forward areas, how Japanese military culture's gender ideology couldn't process the reality of American women serving near combat zones, how American nurses' frontline service shattered Japanese assumptions about women's capabilities, and how this cultural collision revealed fundamental differences between societies that kept women protected by excluding them from military service and societies that protected women by training them to serve wherever soldiers needed them. The Japanese soldiers were shocked, and in that shock lay the recognition that American military organization was fundamentally different and fundamentally more effective than Japanese tradition could accommodate. To understand why Japanese soldiers were shocked by American nurses near front lines, we must first understand the profound cultural divide regarding women's roles in military operations. Japanese military gender doctrine, 1937 to 1945. Japanese military culture, rooted in Bushido traditions and Confucian hierarchies, maintained absolute separation between combat zones, male domain, and home front, female domain. Women's wartime contributions were essential, working in factories, farming, maintaining home life. But these contributions occurred far from actual combat. The Imperial Japanese Army employed women in limited military support roles, but with strict restrictions. Comfort women's system, coerced sexual slavery, a war crime, justified as keeping soldiers' morale while protecting respectable Japanese women from the necessity of such service. Nursing. Japanese Red Cross nurses served in rear area hospitals, typically 50-plus miles from front lines. Communications. Some women worked in rear area signal units. Factory work. Munitions production and supply manufacturing. Civil defense, air raid protection, firefighting, and home islands. Critically, Japanese military doctrine prohibited women from forward deployment. The Senjin-kun, Field Service Code, didn't explicitly mention women because women weren't supposed to be anywhere near combat operations. Japanese military planning assumed women's absence from war zones as a fundamental parameter, requiring no discussion. The rationale was cultural, not practical. Lieutenant Colonel Masanobu Tsuji, influential Japanese staff officer, wrote in 1940, "Women are the source of future soldiers, the maintainers of home order, the moral foundation of Japanese society. Exposing women to combat zone demoralization would corrupt this essential function. Women must remain pure, protected, distant from war's brutality. This is not just military necessity, but cultural imperative. Japanese women's purity distinguishes us from corrupted Western societies." This ideology created operational blind spots. Japanese military planning never addressed medical care for forward units beyond male medics with basic training. The concept of professionally trained nurses operating near front lines was literally outside the framework Japanese military doctrine could conceptualize. When Japanese forces encountered female medical personnel in combat zones, Chinese nurses, Filipino nurses, occasional European nurses, they were treated as aberrations requiring no doctrinal response. These women were either categorized as prostitutes reflecting Japanese military's own comfort women's system or as enemy combatants, justifying harsh treatment or killing. American military nursing, 1941 to 1945. American military nursing operated under a completely different philosophy. The Army Nurse Corps, established 1901, was an integral part of the Army Medical Department, with rank, authority, and professional standing equal to male medical officers. Key principles: professional equality, nurses held officer rank, second lieutenant through colonel, had command authority over male enlisted medics, and received military pay and benefits. Operational deployment: nurses deployed wherever medical care was needed, including forward hospitals. Combat zone service. Regulations required hospitals to be outside artillery range when possible, but operational reality often put nurses much closer to fighting. Medical necessity. Army doctrine prioritized getting wounded to expert care quickly over protecting nurses from combat exposure. Colonel Florence Blanchfield, superintendent of the Army Nurse Corps, explained the philosophy in 1943. Army nurses are military officers performing essential military functions. They are not auxiliaries, not volunteers, not civilian contractors. They are commissioned officers in the United States Army. Their mission is providing expert nursing care to wounded soldiers. This mission requires forward deployment because wounded soldiers are in forward areas. We train our nurses for combat zone operations because that's where soldiers need them. Some argue this exposes women to danger inappropriate for their gender. We respond, soldiers' survival depends on rapid access to expert medical care. Gender is secondary to mission requirements. If nurses must work in dangerous conditions to save soldiers' lives, they will work in dangerous conditions. This philosophy produced radically different operational practice. Typical Japanese medical evacuation chain. Battalion aid station, male medics 0 to 2 miles behind front. Regimental aid station, male medics 2 to 5 miles behind front. Field hospital, some Japanese Red Cross nurses 20 to 50 plus miles behind front. Base hospital, nurses 100 plus miles behind front. Wounded soldiers traveled 20 to 50 plus miles before receiving nursing care. Travel time, hours to days depending on conditions. Typical American medical evacuation chain. Battalion aid station, male medics 0 to 2 miles behind front. Collecting station, male medics 1 to 3 miles behind front. Field hospital, Army nurses and doctors 2 to 10 miles behind front. Evacuation hospital, Army nurses and doctors 5 to 15 miles behind front. General hospital, nurses rear areas. Wounded soldiers receive nursing care within miles of injury, often within hours. The forward presence of professionally trained nurses significantly reduced mortality from shock, infection, and delayed treatment. The operational advantage was measurable. Casualty survival rates, wounded who reached medical care. Japanese military approximately 85% survival rate. American military approximately 96% survival rate. Multiple factors contributed to this difference. Better antibiotics, blood plasma availability, surgical techniques. But forward deployment of expert nursing care was a critical component. American wounded received professional care faster than Japanese wounded, and speed mattered enormously for survival outcomes. Japanese military medical officers recognized American nursing superiority when they studied captured American medical facilities. Report from Japanese medical staff examining captured American Field Hospital, Philippines, 1942. American Medical Organization demonstrates high level of sophistication. Notable features: professional female nurses operate in forward areas, within 10 to 15 kilometers of active combat. This is unprecedented in our experience and initially appeared to be intelligence error. Confirmation from multiple sources indicates Americans routinely deploy female nurses to locations Japanese doctrine reserves for combat troops only. These nurses possess medical training equivalent to or exceeding Japanese military doctors in specialized areas. They perform surgical nursing, manage complex medications, operate medical equipment requiring technical expertise. Captured supplies indicate lavish medical resources, antibiotics, plasma, advanced surgical equipment. Americans apparently prioritize medical care at levels we cannot match with our limited industrial capacity. Most disturbing, system appears to work effectively. American wounded evacuated to forward hospitals receive expert care within hours of injury. Japanese wounded reaching rear hospitals may wait days for equivalent care. Assessment: American medical superiority comes partially from material advantages, but also from organizational willingness to deploy women in dangerous conditions for operational benefit. We cannot replicate this without fundamental cultural change. This assessment, classified and circulated only to senior medical officers, identified the core issue. American operational effectiveness came from being willing to put women in harm's way for military advantage. Japanese culture, valuing women's protection over operational effectiveness, accepted inferior medical care as the price of maintaining proper gender roles. The cultural divide extended beyond official doctrine to personal beliefs. Japanese soldiers were taught that exposing women to combat was morally wrong, a sign of cultural decay and weakness. Real warriors protected women from war's horrors, not brought them into danger. Corporal Tanaka, before his capture, had discussed this with fellow soldiers. Discussion in barracks, January 1945, recalled later. Soldier A: I heard Americans use female nurses near front lines. Is this true? Tanaka: must be propaganda. No civilized people would expose women to combat danger. Americans are degenerates, but not that degenerate. Soldier B: Chinese used female fighters. We saw them. Perhaps Americans are similar? Tanaka: Chinese were desperate, used women because they were losing. Proves their weakness. Japan would never stoop to such measures. Our women remain pure, protected, as proper women should be? Officer: correct. American use of females in military roles demonstrates their cultural corruption. They have lost respect for femininity, for women's proper place. This moral decay is why we will defeat them. They have lost the values that make civilization strong. This conversation, typical of Japanese military attitudes, revealed the fundamental assumption: deploying women near combat zones was a sign of desperation, moral corruption, or both. Strong nations kept women protected and pure. Only weak, desperate nations risked women's lives in military operations. This belief would collide violently with reality when Japanese soldiers encountered American nurses who were neither desperate nor weak, but highly trained professionals performing under conditions Japanese doctrine said women couldn't handle. The first large-scale Japanese encounter with American forward-deployed nurses occurred in the Philippines in 1941-42. During the fall of Manila and Bataan, the experience would shape Japanese perceptions throughout the war. December 1941, April 1942. The Philippines campaign saw American and Filipino forces retreat to Bataan Peninsula, where approximately 100 U.S. Army nurses operated in field hospitals under increasingly desperate conditions. These nurses worked in makeshift facilities that were bombed repeatedly, treated thousands of casualties with dwindling supplies, and continued operating even as Japanese forces closed in. When Bataan fell in April 1942, most nurses evacuated to Corregidor and then to Australia, but Japanese forces captured several and documented the facilities they found. Japanese Medical Officer Inspection Report, Bataan, April 1942. Examined abandoned American Hospital Number 1. Evidence indicates professional female nurses worked here until final evacuation. Facility located 8 kilometers from frontline positions during recent fighting, within artillery range, certainly within bombing range as evidenced by damage to buildings. Female uniforms found indicate nurses held officer rank. Medical records show nurses performed surgical assistance, post-operative care, trauma management, responsibilities Japanese Red Cross nurses perform only in rear hospitals under supervision. Most remarkable, records indicate nurses remained at posts during Japanese bombing raids, treating casualties while under attack. This contradicts our understanding of female psychology and capabilities under combat stress. Assessment. Americans demonstrate either reckless disregard for female safety or possess female personnel with resilience unexpected from women. Uncertain which interpretation correct. This uncertainty, whether American deployment of women was recklessness or effectiveness, would persist throughout the war as Japanese soldiers repeatedly encountered American nurses operating under conditions Japanese culture deemed impossible for women. The captured nurses from Bataan, approximately 77 Army and Navy nurses taken to Santo Tomas internment camp in Manila, presented their own puzzle to Japanese authorities. These women had served in combat zones, yet didn't fit Japanese expectations for either soldiers or prostitutes. They were professionals, educated, officer-ranked military personnel who happened to be female. Japanese camp administrators struggled with how to categorize them. Eventually, they were treated as civilian internees despite their military status, a classification that avoided confronting the cognitive dissonance of recognizing women as military officers. But the majority of American nurses weren't captured. They continued serving in forward hospitals throughout the Pacific as American forces advanced. Japanese soldiers wounded and captured during these advances encountered these nurses personally, experiencing the collision between ideology and reality. Corporal Tanaka's experience in the Philippines in February 1945 exemplified this encounter. Field Hospital, Luzon, Philippines, February 1945. I awoke expecting execution. Instead, I found myself in clean bed being treated by American doctor and American nurse. Female, military uniform, captain's rank. This was incomprehensible. The nurse, her name was O'Brien, I learned later, worked with absolute professionalism. She changed my bandages, checked my wounds for infection, administered medications. She showed no fear, no uncertainty, no feminine weakness Japanese culture taught me to expect. Most shocking, the hospital came under Japanese artillery fire on my second day there. American male orderlies showed fear, moved nervously. Captain O'Brien continued working. When shell landed close enough to shake the building, she steadied a patient's IV without pausing in her work. She displayed more courage than many soldiers I had served with. This contradicted everything I believed about women. Japanese women were nurturing, gentle, requiring protection. This American woman was nurturing in her medical care, but hard as steel in her professional conduct. She operated in conditions I would not have wanted to face, and she did it routinely, apparently without considering it unusual. Over the next week, I watched American nurses work 16-hour shifts, treating casualties from heavy fighting. They performed under exhaustion, under stress, occasionally under fire. They maintained professional standards that exceeded many Japanese military doctors. One nurse, Lieutenant Wilson, continued working after sustaining minor shrapnel wounds when shell hit nearby building. She had her wounds bandaged by corpsmen and returned to treating patients within an hour. This behavior would be remarkable in male soldier. In female, it was incomprehensible to me. I realized everything Japanese military taught me about women's capabilities was wrong, or everything American military taught their women was fundamentally different. Perhaps both. Tanaka's realization repeated across thousands of Japanese POWs who encountered American military nurses. The cognitive dissonance created by observing women performing under conditions. Japanese doctrine said women couldn't handle forced reconsideration of fundamental beliefs. The American nurses themselves were aware of the impact they had on Japanese prisoners. Captain Margaret O'Brien, recorded interview 1946. Japanese prisoners were visibly shocked when they realized women were treating them. Not shocked by the treatment, shocked that women were there at all in a combat zone. Some Japanese wounded tried to refuse treatment from female nurses, claiming it was dishonorable. We worked through interpreters to explain that in American military, nurses were officers with authority to direct their medical care. They could accept treatment or they could accept whatever happened to untreated wounds. Most accepted treatment. What struck me was how their attitudes changed over days and weeks. Initial shock and discomfort transformed into confusion, then grudging respect, sometimes genuine appreciation. They couldn't reconcile what they'd been taught about women with what they were observing. I had Japanese prisoners ask me through interpreters, "Are you not afraid? How can you work in such conditions? What about your family? Do they not worry?" These questions revealed that they couldn't process how women ended up in combat zones performing duties they thought only men could handle. My answer was always the same. I'm an Army nurse. This is my job. Soldiers need medical care. I provide it. My gender is irrelevant to my professional capabilities. This concept that gender could be irrelevant to professional competence seemed revolutionary to them. The professional competence American nurses demonstrated was itself shocking to Japanese observers. Japanese military culture assumed women's medical skills were inherently limited, suitable for basic nursing but not for complex combat trauma care. American nurses performing advanced medical procedures contradicted these assumptions. Lieutenant Hiroshi Yamamoto, Japanese medical officer captured on Okinawa, witnessed this. I was wounded during American bombardment and taken to American field hospital. My expectations were execution or at best minimal care from enemy. Instead, I received immediate professional treatment from American nurse working with American surgeon. The nurse, I never learned her name, remember only her efficiency, managed my preoperative care, assisted during surgery to remove shrapnel from my abdomen, and provided post-operative monitoring. Her skills exceeded many Japanese military surgeons I had worked with. She operated medical equipment I had only seen in photographs. She administered medications with precision Japanese military struggled to match given our supply limitations. This was profound shock. Enemy nurse, female, demonstrated greater medical competence than Japanese military doctor, male, with years of training. How was this possible? After my recovery, I observed this hospital for weeks as prisoner. American nurses routinely performed procedures Japanese doctrine reserved for doctors. They managed complex medication regimens. They operated advanced medical equipment. They made clinical decisions independently. I realized American military had professionalized nursing to a degree Japanese military couldn't match. Our nurses were caregivers. American nurses were medical specialists with authority and training approaching doctors in many areas. This professionalization allowed them to operate effectively in forward areas because they were genuinely competent to handle complex medical situations independently. Japanese military had failed to develop nursing as genuine profession. We had kept it as subordinate role requiring minimal training, keeping women in positions reflecting cultural expectations rather than developing their capabilities. Americans had developed nursing as true medical profession, giving women training and authority to match their responsibilities. Result, American wounded received better care faster because American nurses could do more. Japanese wounded received slower, less expert care because Japanese nurses couldn't do as much and weren't deployed forward anyway. This assessment that Japanese cultural restrictions on women's roles had created operational disadvantages was shared by other Japanese medical personnel who encountered American military nurses. Captured Japanese Medical Officers Collective Assessment, 1945. American deployment of female nurses in forward areas provides significant operational advantages. Rapid expert care. Wounded receive professional nursing within hours of injury rather than days. This reduces mortality from shock, infection. Complications. Continuity of care. Same nurses manage patients from initial treatment through recovery, providing better outcomes than Japanese system where wounded pass through multiple facilities with different personnel. Professional specialization. American nurses specialize in combat trauma care, developing expertise our nurses never acquire because they're kept in rear areas treating primarily disease and routine illness. Force multiplication. Professional nurses allow doctors to focus on complex surgical cases while nurses manage routine care independently. Japanese system requires doctors to supervise all care, reducing efficiency. Morale effect. American wounded know they will receive expert care quickly. This knowledge reduces combat stress and encourages wounded to seek treatment promptly. Japanese wounded know care may be delayed days, creating fatalism that reduces survival rates. Conclusion. American willingness to deploy women in dangerous conditions produces measurable operational benefits. Japanese cultural preference for keeping women protected produces measurable operational costs. We must acknowledge, Americans demonstrated that women can function effectively in combat zone medical roles. Japanese assumptions about women's incapability under combat stress are contradicted by observed evidence. Cultural ideology prevented us from developing nursing capabilities that would have improved our combat medical outcomes. This assessment, never widely circulated during the war, represented remarkable intellectual honesty, acknowledging that American cultural practices, deploying women near combat, produced better results than Japanese cultural practices, keeping women protected in rear areas, even though this admission contradicted fundamental Japanese beliefs about proper gender roles. Beyond the professional medical competence, Japanese soldiers were shocked by American nurses' personal conduct under fire. Japanese ideology taught that women were emotionally fragile, would panic under stress, required male protection in dangerous situations. American nurses repeatedly demonstrated the opposite. Documented incidents that shocked Japanese observers. Okinawa, April 1945, Army nurse Lieutenant Frances Slanger continued treating wounded during Japanese artillery bombardment that killed 2 patients and wounded several staff. She directed evacuation of mobile patients, remained with immobile patients through the bombardment, and returned to normal duties once the shelling stopped. Japanese soldiers who witnessed this through field glasses reported it to intelligence officers who initially dismissed the reports as misidentification, assuming the person described must have been male medic, not female nurse. Philippines, January 1945. When Japanese infiltrators attacked field hospital, Army nurses evacuated patients while armed guards engaged the attackers. Nurse Captain Ann Walker personally evacuated 3 bedridden patients under fire, making multiple trips into exposed areas to reach patients who couldn't move themselves. Japanese prisoners later stated they had targeted the hospital specifically because intelligence said it would be lightly defended, not expecting the level of organized resistance they encountered from medical staff. New Guinea, 1943, when transport plane carrying evacuated wounded and army nurses crashed in jungle. Nurses survived the crash and organized survival for wounded passengers over 5 days before rescue. They rationed limited food, treated injuries with improvised materials, and maintained patients' medical care using salvaged supplies. The Japanese patrol that discovered the crash site reported finding organized medical operation in the jungle, led by female officers. Japanese command initially refused to believe the report, assuming it was confused description of male medics. These incidents, documented from both American and Japanese sources, demonstrated that American nurses weren't just present near combat zones. They actively functioned under combat conditions with effectiveness that Japanese military culture said women couldn't achieve. By late 1944 and into 1945, as Japanese defensive positions crumbled across the Pacific, thousands of Japanese soldiers encountered American military nurses. The cumulative impact of these encounters forced reconsideration of fundamental beliefs about women's capabilities and proper gender roles. The scale of American nursing deployment impressed even Japanese observers who maintained ideological commitment to keeping women away from combat. Japanese Intelligence Assessment, November 1944. American Medical Organization in Pacific Theater employs approximately 17,000 female nurses, Army and Navy combined. These nurses operate in forward hospitals across entire Pacific Theater, typically within 5 to 15 kilometers of active combat. Distribution indicates Americans deploy nurses wherever medical facilities operate, regardless of proximity to fighting. We have confirmed female nurses on New Guinea, all forward hospitals. Philippines, all forward hospitals. Marianas, all forward hospitals. Various small islands, field hospitals. This represents systematic deployment policy, not isolated cases. Americans have made forward presence of female medical personnel integral part of combat medical organization. Operational impact. Americans achieve casualty evacuation and treatment times Japanese system cannot match. Wounded receiving expert nursing care within hours shows measurably better survival rates than our system, where expert care requires days of evacuation. Cultural implications. American willingness to expose thousands of women to combat zone dangers indicates either moral corruption and loss of respect for femininity, or cultural differences so profound that Americans literally perceive gender roles differently than Japanese, or operational pragmatism that prioritizes military effectiveness over cultural ideals. Previously, we dismissed American practices as corruption and weakness. Observed effectiveness of their system suggests third interpretation may be correct. Americans achieve operational advantages by ignoring cultural restrictions we maintain. Recommendation: traditional Japanese values regarding women's protection are morally correct and culturally essential. However, we must acknowledge these values impose operational costs. American system produces better medical outcomes by violating restrictions we maintain. We cannot adopt American practices without fundamental cultural change. But we must stop dismissing American approach as simple weakness. Their system works better than ours. This is uncomfortable truth that contradicts our ideology but is confirmed by observable evidence. This assessment, distributed to senior commanders, represented significant evolution in Japanese military thinking, acknowledging that American cultural practices produced operational advantages even while maintaining that Japanese cultural values were morally superior. But for individual Japanese soldiers who directly encountered American nurses, the impact was more personal and profound. Corporal Kenji Tanaka, after weeks in American custody. My understanding of reality was shattered by American nurses, not dramatically in single moment, but gradually through accumulated observations that contradicted everything I believed. I believed women were weak. I watched Captain O'Brien work 18-hour shifts treating casualties from brutal fighting, maintaining professional composure that many male soldiers couldn't match. I believed women panicked under stress. I observed nurses continue working when artillery shells landed near hospital, when Japanese infiltrators approached perimeter, when supply shortages created desperate conditions. I believed women required male protection. I saw nurses evacuate wounded, organize defensive measures, operate in conditions where protection was luxury nobody could provide. I believed women's proper role was nurturing and gentle. American nurses were nurturing in their medical care, but simultaneously harder, more professional, more capable than I had thought possible for women. My culture taught me that protecting women from war was moral imperative. American practice demonstrated that preparing women for war service and deploying them where soldiers needed them produced better outcomes. Which approach actually valued women more, protecting them from developing capabilities, or training them to serve effectively? This question, whether true respect for women meant protecting them from danger or enabling them to serve capably, troubled many Japanese POWs who encountered American nurses. The most profound impact came when Japanese wounded experienced American nursing care and compared it to Japanese military medical treatment. Private Ichiro Suzuki, captured on Iwo Jima with severe burns. I was burned when flamethrower caught our position. Japanese military medicine had no treatment for severe burns beyond bandages and morphine, if available. I expected to die slowly from infection and pain. American medics evacuated me to field hospital where nurses specialized in burn treatment. Over weeks and months, they managed complex treatment, debridement, infection control, skin grafts, pain management, psychological support for burn victims. The nurse primarily responsible for my care, Lieutenant Patterson, worked with precision and empathy I had never experienced from Japanese military medical personnel. She explained procedures, managed my pain, monitored for complications, and provided psychological support during moments when I wanted to die from pain and disfigurement. After 3 months, I had healed enough to be transferred to POW camp. My burns had healed with minimal scarring. American nurses had saved my life and preserved my function using techniques Japanese military medicine didn't possess. I realized I survived with acceptable outcome because enemy nurses treated me with expertise Japanese military medicine couldn't match. My own military would have let me die or left me permanently disabled. Enemy nurses, female, operating in conditions Japanese culture said women shouldn't experience, saved me. This gratitude was mixed with shame. Shame that enemy was more capable than my own forces. Shame that my culture's restrictions on women's roles had prevented us from developing comparable capabilities. Shame that I owed my life to enemy females while Japanese males had failed to develop equivalent medical capacity. The shame, recognizing that cultural ideology had produced operational inferiority, appeared repeatedly in Japanese POW testimonies about American nurses. Some Japanese prisoners maintained ideological commitment despite evidence. Sergeant Masao Taniguchi, captured on Okinawa, interviewed 1946. American nurses were capable, yes. They worked under conditions I wouldn't have expected women to handle, but this doesn't justify their use. Women should not be exposed to war's horrors. This is moral principle, not practical calculation. Americans achieved operational benefits by violating proper gender roles. This is like achieving victory by abandoning honor. You may win, but you lose something more important than victory. Japanese culture's insistence on protecting women is one of our greatest strengths, not weakness. We may have lost the war, but we maintained our values. Americans may have won, but they corrupted their women by exposing them to experiences that will damage their femininity forever. I respect the competence of American nurses I encountered. I do not respect the culture that put them in those positions. Some principles are more important than operational efficiency. This position, maintaining ideological purity despite operational costs, represented one response to the cognitive dissonance created by encountering capable American nurses. But other Japanese POWs reached different conclusions. Lieutenant Takeshi Nakamura, former medical officer. Before the war, I studied Western medicine and Western medical organization. I knew Americans trained nurses to higher standards than we did. But I dismissed this as Western excess, training women beyond what their roles required. After encountering American military nurses in combat zones, I understood. They weren't overtrained. They were appropriately trained for the roles Americans asked them to fulfill. We were undertraining our nurses because we artificially restricted their roles based on cultural ideology rather than operational requirements. The question isn't whether women can function in combat zone medical roles. American nurses prove conclusively they can. The question is whether our cultural resistance to women's expanded roles costs us operational capability. The answer, based on my observations, is unquestionably yes. This is bitter pill. American culture's greater flexibility regarding gender roles produced military advantage. Our culture's rigidity produced military disadvantage. We can maintain our ideology and accept operational inferiority, or we can adapt our culture to operational reality. I suspect Japan will choose adaptation, not because we want to, but because evidence of American nursing's effectiveness is too overwhelming to ignore. The nurses who saved Japanese wounded demonstrated capabilities our ideology said women didn't possess. This evidence cannot be unseen. The post-war period brought a final reckoning as Japanese society processed what its soldiers had learned about American women's capabilities. The transformation was neither immediate nor complete, but the evidence from Japanese POWs who had encountered American nurses provided undeniable documentation that challenged Japanese gender ideology. Repatriated Japanese soldiers returned home with stories that contradicted traditional beliefs. Collective testimony from repatriated POWs, 1946. We were captured expecting execution or brutal treatment. We encountered professional medical care from both male and female American military personnel. The female nurses worked in conditions we thought impossible for women, near front lines, under fire, managing complex trauma cases. These experiences force us to reconsider what we were taught about women's capabilities. We don't claim American practices are morally superior to Japanese traditions, but we must acknowledge American practices produced measurably better medical outcomes. Many of us survived because American nurses provided expert care we wouldn't have received in the Japanese system. This survival came from enemy females working in roles Japanese culture reserves for males. We cannot dismiss this as propaganda. We lived it. Japanese medical professionals, particularly those who had been military doctors and encountered American practices, became advocates for nursing professionalization. Dr. Minoru Sasaki, former Japanese military surgeon, writing in 1948, "Japanese nursing must evolve. We maintain nursing as a low-status support role because cultural ideology restricted women's professional development. American nursing, developed as a genuine medical profession with advanced training and significant authority, proves superior in wartime and will prove superior in peacetime. The evidence is overwhelming. The American system with forward-deployed professional nurses achieved better casualty outcomes than the Japanese system with rear-deployed limited training nurses. This wasn't due to American moral superiority, but to practical recognition that professional nursing provides operational advantages. Post-war Japan must develop nursing as a true profession. This means university-level nursing education, professional autonomy and authority for nurses, recognition that women can handle high-stress medical environments, integration of nurses into all levels of medical organization. Some will argue this corrupts traditional Japanese values. I respond, traditional values that prevent us from providing the best possible medical care must be reconsidered. Americans demonstrated that women can function professionally in high-stress environments. We must learn this lesson. The occupation period, 1945 to 1952, accelerated this transformation. American military nurses serving with occupation forces demonstrated their capabilities directly to Japanese civilians. American influence on Japanese medical education included a strong emphasis on nursing professionalization. By the 1950s, Japanese nursing education had begun transformation toward a professional model, influenced heavily by the American example. While Japanese nursing would retain culturally specific characteristics, the movement toward university education, professional autonomy, and expanded roles was undeniable. But the more profound transformation was cultural. Japanese society's gradual recognition that women's capabilities exceeded traditional restrictions. Public Opinion Survey Japan, 1952. Question: do you believe women can work effectively in high-stress professional environments, such as medical care during emergencies? 1945, preoccupation, yes 23%, no 58%, uncertain 19%. 1952, during occupation, yes 67%, no 18%, uncertain 15%. Question: should women be restricted from certain professions to protect them from stress or danger? 1945, should restrict 71%, should not restrict 15%, uncertain 14%. 1952, should restrict 28%, should not restrict 51%, uncertain 21%. These dramatic shifts reflected multiple factors: occupation influence, economic necessity, exposure to Western media. But testimonies from returning POWs about American nurses' capabilities played a significant role in challenging traditional assumptions. American nurses who had served in the Pacific reflected on their impact. Colonel Florence Blanchfield, Superintendent of Army Nurse Corps, 1947. Our nurses served near front lines throughout the Pacific War not to make a political statement about gender roles, but to save soldiers' lives. That was always the mission: provide the best medical care possible in the shortest time possible. That this required deploying women in dangerous conditions was a secondary consideration. Soldiers needed expert nursing care. Nurses provided it. The fact that nurses were women and therefore working in areas some cultures thought inappropriate for women was, from an operational standpoint, irrelevant. What we learned: women can function professionally under conditions traditionally assumed to be male-only domains. Not some women, not exceptional women, generally when properly trained and supported. I'm proud of our nurses' service. They performed superbly under extremely difficult conditions. They saved thousands of lives. They demonstrated professional excellence that contradicted gender stereotypes. And they did all this while facing a double burden: combat zone stress plus societal assumptions that women shouldn't be there at all. The Japanese soldiers who were shocked by our nurses learned what we already knew: women's capabilities, when properly developed and deployed, exceed traditional cultural restrictions. This isn't about whether women should serve in combat zones. It's about recognizing that when operational necessity requires it, women can and will serve effectively. Individual nurses reflected on Japanese reactions to their presence. Captain Margaret O'Brien, interviewed 1948. The Japanese prisoners were genuinely shocked we were there, not shocked by the care we provided, but shocked that women were providing it near front lines. Their shock revealed how limited their cultural assumptions were about women's capabilities. I didn't serve near front lines to prove a point about gender equality. I served there because wounded soldiers were there and needed nursing care. My gender was incidental to my professional function, but I recognize that by simply doing my job, I contradicted Japanese assumptions about what women could do. Many Japanese prisoners told me through interpreters that they'd never imagined women could work under such conditions. They'd been taught women were too emotionally fragile, too physically weak, too psychologically unsuited for combat zone stress. Watching women perform professional medical care under artillery fire, during Japanese attacks, under conditions of exhaustion and deprivation, this shattered their assumptions, not through argument or propaganda, but through direct observation. I think this was valuable education for them, not just about American military organization, but about human capabilities generally. Cultural assumptions about what women can't do often reveal more about the culture than about women. Japanese culture's restrictions on women prevented the Japanese military from utilizing half their potential human capital effectively. I hope some of those Japanese prisoners returned home and questioned whether their culture's gender restrictions served Japan well. Not because American ways are automatically better, but because evidence suggested their restrictions imposed real costs. The story of Japanese soldiers shocked by American nurses near front lines represents more than military medical history. It represents the collision between cultural ideologies about gender and operational reality of modern warfare. Final statistics. U.S. Army Nurse Corps service in Pacific 1941 to 1945. Nurses deployed 17,000 plus, Army and Navy combined. Hospitals staffed 400 plus facilities across Pacific Theater. Average distance from front lines, 2 to 15 miles, much closer than Japanese deployment. Casualties treated, 500,000 plus American and Allied troops. Casualty survival rate, those reaching medical care, 96%. Nurses killed by enemy action, 201, from all causes including POW camps, bombings, etc. Nurses wounded, 1,600 plus. Decorations, 1,600 plus medals including Distinguished Service Medals, Silver Stars, Bronze Stars, Purple Hearts. Japanese Red Cross nurses. Nurses deployed approximately 33,000 throughout war. Average distance from front lines 50 to 100 plus miles. Casualty survival rate approximately 85%. Nurses killed, significantly higher proportion due to rear area bombing of home islands. Comparative outcomes. American wounded receiving nursing care within hours of injury had survival rate 11 percentage points higher than Japanese wounded who waited days for nursing care. This difference represented thousands of lives saved through forward deployment of professional nurses. The operational advantage was clear and measurable. American cultural willingness to deploy women in dangerous conditions produced better medical outcomes than Japanese cultural insistence on keeping women protected in rear areas. In the National Museum of American History in Washington, D.C., an exhibit on Army nurses features testimonies from both American nurses and Japanese POWs who encountered them. American perspective. Captain Margaret O'Brien. We went where wounded soldiers were because that's where nurses were needed. The fact that this meant working near front lines under fire in dangerous conditions was secondary to our mission. We were there to save lives. Japanese prisoners' shock at our presence revealed their culture's limitations more than our culture's strengths. They couldn't imagine women functioning in combat zone medical roles because their culture never developed women's capabilities to that level. I don't claim American culture was superior. I claim American operational pragmatism produced better medical outcomes. We used our full human capital, including women's professional capabilities. They restricted women based on ideology, and it cost them operationally. The Japanese wounded I treated received the same professional care as American wounded. Many survived because we were there, close enough to provide expert care quickly. I'm proud we saved enemy lives. That's what medical professionals do. We save lives regardless of politics or nationality. But I'm also aware that our presence there contradicted Japanese soldiers' fundamental beliefs about women's capabilities and proper roles. For some, this was a liberating realization. For others, it was disturbing evidence that their culture's values produced operational disadvantages. Either way, they learned that women can function professionally in conditions their culture said women couldn't handle. Japanese perspective, Kenji Tanaka, writing in 1965. 20 years after the war, I still remember Captain O'Brien and the American nurses who saved my life. Their professional competence shattered my understanding of women's capabilities and limitations. I was raised to believe women were precious and fragile, requiring male protection from life's harshness. I believed this absolutely. Then I encountered American women working calmly under artillery fire, treating casualties with expertise exceeding many Japanese doctors, maintaining professional standards under conditions I found difficult to endure. This contradiction forced me to reconsider everything I'd been taught. Not immediately, the cognitive dissonance was too great. But over months and years, I came to understand my culture's restrictions on women's roles weren't protecting women. They were limiting women's development and costing us operational effectiveness. American nurses weren't less feminine for serving in combat zones. They were more fully developed as professionals. Their culture had prepared them for roles our culture said women couldn't fill, and they succeeded spectacularly in those roles. Post-war Japan has slowly recognized this lesson. Japanese nurses today receive professional training unimaginable in 1945. Japanese women enter professions we once reserved for men. This transformation came partly from American occupation influence, but also from thousands of Japanese soldiers who encountered American nurses and realized women's capabilities exceeded our cultural assumptions. I am grateful to American nurses for saving my life. I am also grateful for the lesson they taught that cultural restrictions on women's capabilities may reveal more about the culture than about women. Japan has been slow to learn this lesson, but we are learning it. 20 years later, I remember the shock of seeing women operating near front lines. I remember thinking it was impossible, improper, culturally wrong. I also remember realizing those women were saving lives more effectively than my own military's medical system. This contradiction demanded resolution. Resolution came through recognizing that operational effectiveness matters more than cultural ideology. American nurses demonstrated this through their service. They shocked us by simply doing their jobs professionally under conditions we thought women couldn't handle. In that shock lay education we desperately needed. The Japanese Military Museum in Tokyo includes an exhibit on American military nursing, with explanation of how encountering American nurses affected Japanese soldiers' understanding. American deployment of female nurses in forward hospitals during Pacific War initially appeared incomprehensible to Japanese forces. Japanese military culture emphasized protecting women from combat zone dangers. American practice demonstrated that women could function professionally in high-stress medical environments when properly trained. Japanese soldiers captured and treated by American nurses encountered this reality directly. Post-war Japanese nursing professionalization was influenced by this recognition that women's capabilities, when fully developed, exceeded traditional cultural restrictions. American military nurses' wartime service provided evidence that cultural assumptions about women's limitations were not universal truths, but culturally specific restrictions that imposed operational costs. Modern Japanese nursing reflects lessons learned from this encounter. Emphasis on professional education, expanded scope of practice, recognition that gender is secondary to professional competence in medical care. The story of Japanese soldiers shocked by American nurses represents cultural collision with measurable outcomes. Japanese ideology that kept women away from combat produced inferior medical outcomes. American pragmatism that deployed women where needed produced superior outcomes. This wasn't about moral superiority. Both cultures had valid values regarding women's protection and respect. But operational reality demonstrated that protecting women by restricting their development and deployment produced worse outcomes than preparing women for professional service and deploying them where needed. The American nurses who served near Pacific Front lines weren't trying to make political statements about gender equality. They were providing medical care where it was needed most, near wounded soldiers who would die without rapid expert treatment. That this service contradicted Japanese assumptions about women's capabilities was a secondary effect, not primary purpose. But that secondary effect had profound impact. Thousands of Japanese soldiers learned through direct observation that women could function professionally under conditions their culture said women couldn't handle. The lesson wasn't American culture superior to Japanese culture. Whereas the lesson was cultural assumptions about human capabilities should be tested against observed evidence, not maintained despite contradictory evidence. Japanese soldiers were shocked when they encountered American nurses operating near front lines. That shock forced confrontation with evidence that their culture's gender ideology imposed operational costs. The transformation that followed, slow, incomplete but undeniable, reflected recognition that observed reality trumps cultural ideology when lives depend on it. The American nurses weren't trying to shock anyone. They were trying to save lives. That they succeeded, while simultaneously shattering Japanese assumptions about women's capabilities, stands as a tribute to their professional excellence and to the wisdom of military organization that deploys human capital based on capability rather than cultural restriction.